Hello, everyone. Good morning or good afternoon, depending on where you are. First of all, thank you all for attending this webinar. This is the third webinar of our series between EUCIC and EU-JAMRAI. For those who have missed the previous ones, they're available on the ESCMID webpage. My name is Konstantinos Tsoudis. I'm from the steering committee of EUCIC, and today we have a great panel of chairs and speakers. The topic of our webinar today is surveillance of infectious diseases, a very important subject, and how to match it with implementation of IPC. So that's that from me, and now I will give the floor to our two chairs. A big thank you also to ECDC for co-organizing and supporting today's webinar. So we have Angelo and Tommy who are chairing this session. So thank you very much for being here. The floor is yours. Angelo, you're muted.
Yes, hello. There's a bit of an echo. Or is it already me? Not me. If I try to speak. Yes, so welcome everyone.
Okay, we have some.
Is there any other microphone on in the audience?
Yeah. No. It's from Tommy. Some audio issues.
Okay, maybe in the meantime I can introduce the.
Of course, yeah. Thanks.
I'm Angelo D'Ambrosio, healthcare associated infection expert at the CDC, working mostly on cross-serious difficile surveillance. And Tommy is my fellow and more senior colleague, working on since many years at the CDC as a healthcare associated infection expert on multiple series of surveillances in the current years. Tommy, were you able to fix so that you can introduce the first speaker?
Maybe now.
Yes, it works.
Yes. Yeah, apologies for this. I actually still have an echo. Nevertheless, welcome everyone. Welcome everyone to this webinar. And I will briefly introduce my colleague, Diamantis Plakouras, who is the current head of section of antimicrobial resistance and healthcare associated infections at European Centre for Disease Prevention and Control. And he has, of course, extensive experience in infection prevention and control and surveillance of healthcare associated infections at several different levels, and also in preparing and consulting on guidelines on infection prevention and control and surveillance, and currently works at, of course, at the European level since several years. So without further ado, the floor is yours, Diamantis.
Diamantis, one second before you start. For the audience, you can write your questions in there is the question and answer box, and we will read them at the end of the first presentation.
Thank you so much, Angelo. Thank you so much, Tommy, for the introduction. And I would also like to thank EUCIC and JAMRAI for the invitation to talk about the implementation of sustainable surveillance programs. And of course, we will focus mostly on surveillance of healthcare associated infections. So I think what we need, what I will touch in the next 20 minutes is first of all, identifying the targets for the target infections for surveillance, which I think is very important first step to make sure that the system is sustainable. And then, but I will focus more on the challenges of conventional surveillance and how automation and a bit recently also artificial intelligence can help achieve sustainable surveillance. So I mean, surveillance in general in infectious diseases is the systematic collection, analysis, and interpretation of data. And we know since the late 70s, it was the landmark CENIC study that showed that surveillance is a core component of effective infection prevention and control programs. And this has also been, surveillance is also now included in the core components of IPC published by WHO. And this is supported by really a lot of data. But we shouldn't forget that surveillance is done to drive action. So we do surveillance either to identify outbreaks or to identify targets for improvement in infection prevention and control. And this is very important when reflecting how to set up a sustainable surveillance system. So when we are considering this, there are some questions we have to answer. First of all, which infections are going to be a target for surveillance? It can be, ideally, it would be all healthcare-associated infections, but that probably isn't always feasible. So it could be bloodstream infections, or more specifically, catheter-related bloodstream infections, or catheter-associated urinary tract infections. It could be surgical site infections, or pneumonia, or Clostridioides difficile infections, or a combination of these, or all of these, right? But we also need to reflect on where, which parts of the hospitals are we going to do surveillance. Will it be all wards, or will it be targeted to wards such as the intensive care unit, or hematology oncology, or other medical or surgical wards? Of course, again, ideally, we would like to have all wards, but sometimes, and we will see why this might not be possible. And then what type of surveillance are we going to be doing? Is it going to be incident surveillance, like measuring on an ongoing basis the healthcare-associated infections under surveillance, or will we be doing just some most likely repeated prevalence surveys that require fewer resources to do, but can also cover all types of that we are interested in, and also their data, although they provide just a snapshot of the epidemiological situation, they can be useful to make inferences, for instance. And in our for this decision, there are a number of factors that will help us decide. And of course, one major factor, as we will also see later, is the resources that we have available, or perhaps we want to ask for more resources, but also the feasibility, whether the data that we need for surveillance are available, whether what we have in mind is measurable. An important factor is, as the data are meant to drive action, is whether what we're measuring is preventable. And a very important factor is whether it's clinically relevant, because we'll have to, when we move to measures, we'll have to convince our the clinical staff involved that what we're asking them to do makes sense, and what we're measuring makes sense. And of course, there may be national requirements for surveillance, and if we're lucky, there will be a local, regional, or even national network that we can collaborate with, and that to help us set up the surveillance. So conventionally, surveillance of healthcare-associated infections is done through a manual retrospective chart review. So someone is on the ward, regularly measuring and identifying the cases. But this, of course, is very time-consuming. And then there is also that this person applies some case definitions, which makes it prone to subjective interpretation. So different persons may interpret the definitions differently. And usually also this leads to, because the analysis, the collection of data, analysis, and interpretation take time, we may have delayed reporting. And in Europe, as shown by the latest point prevalence survey of healthcare-associated infections in 2022-2023, we can see that there is a large variability in collaboration in surveillance networks for different infections shown here on the left side for surgical site infections and on the right side for ICU surveillance. So surveillance is not established and running everywhere. And when we looked at the factors that don't make it easy to establish surveillance in 2018, the main factors were that it's very labor intensive and there is a lack of resources to perform surveillance in hospitals. And this is where the automation comes in. And when we're talking about automation, automated surveillance is any form of surveillance where at least parts of the manual assessment are replaced by automated process. And this means that we are using the already available data on the electronic health record and we need to link the clinical data, for example, with the laboratory data, and then apply an algorithm to this data set. And from that algorithm can either directly decide that there is a healthcare-associated infection, and this is a case of full automation, so we don't need any manual review, or this algorithm can identify a subset of patients with high risk of an infection. And then what follows is a conventional manual site review, but the advantage, of course, in this case is that the workload is much less, so it's much easier to perform. And this is what one calls semi-automated surveillance. So automation means that surveillance is less resource demanding, so addressing one of the main drawbacks of surveillance, the main factors, the main barriers, I would say. But it also makes surveillance more standardized and less prone to error and subjective interpretation, and can even make possible real-time surveillance. Are we there yet in terms of automation? We asked this question in the last point prevalence survey of healthcare-associated infections. And one of the questions was to ask the hospitals whether they had any degree of automation, whether they had, let's say, semi-automated or automated or fully automated surveillance. And among 900 hospitals that answered this question, only 600 to around 800, depending on the type of surveillance, had surveillance in place. And in more than half of these cases, there was no automation, so it was fully manual. But there was around close to 20% of hospitals that reported they had some automation, and less than 5%, around 3%, that reported full automation. And again, as the map shows, in the right, this was differed a lot across the countries. We also asked what is the feasibility of automation in the future. And for this, we asked whether the data in the electronic health record were available in digital form, and if they were available in digital form, whether the data were structured and well-defined. And this is a very important attribute to establish fully automated surveillance. And what we found was that whether for some variables, such as administrative variables and, for example, the microbiology results, there was usually the data were in digital form and even in structured and well-defined form. For other variables that are necessary for surveillance of healthcare-associated infections, like the use of central lines or mechanical ventilation, this was less often the case. So it seems that we're not there yet everywhere, but things are, of course, are improving, and there is a lot of potential. At the CDC, we established a project in 2023 that this was part of a larger project for setting up electronic health record-based surveillance. And this project focuses on healthcare-associated bloodstream infections. And for this project, there are 19 currently countries that are participating and 7 observer countries. And why was bloodstream infections the target? I mean, the easy answer is that it's a very easy target, because for bloodstream infections, the case definition does not require a lot of clinical data, which we know are inconsistently reported and require complicated data collection tools to extract. And also, healthcare-associated bloodstream infections are a key surveillance target. They are severe infections, they are common, they're easily definable, and in many cases preventable. We also thought that this could be kind of a proof of concept that could be used as a model for future development of automated surveillance of other infections. And in the short term, the objective of this has been to support the countries to establish automated surveillance systems based on electronic health data, like, for example, by providing standardized case definitions and supporting database linking. But in the long term, of course, we would like to see surveillance of healthcare-associated bloodstream infections at a European level, and also surveillance of other pathogens like that are not currently under surveillance, like emerging ones such as Candidosima auris, and eventually also automate surveillance of antimicrobial resistance. One of the main issues when we're talking about surveillance based on electronic health record data is that the health data that we use for surveillance usually originates from very diverse sources, and they have different formats, scope, and content. I mean, they're not made for surveillance in the first place, and they can be structured or unstructured. So there is a need, if we want to have, for example, a surveillance network or collate data from different healthcare facilities, there is a need for harmonization in accordance with health data standards. And this need is there both for the data as such, so the coding system, but also for the data model, so that in effect, there needs to be a translation from the local systems to a reference terminology and a reference data model. And this is one of the challenges. Other challenges that we have identified through this project and that have been very often reported from the countries are, of course, a lack of human resources that are needed for the establishment of such a system. And of course, a lack of financial resources. Again, there is a need for significant financial resources, at least for setting up, but also eventually for maintaining the system. Lack of expertise and lack of infrastructure. But there are also specific challenges that have to do with data linkage. And these can be both technical challenges that have to do with the terminologies and the data models, but also legal challenges with data protection. In the last, I mean, automated surveillance is not a new idea. It has been on the table since before the 2000s. But in the recent years, there have been really significant developments, and there have been several algorithms for almost all healthcare-associated infections. This one, for example, is a study where colleagues in Switzerland developed an algorithm for automated surveillance of catheter-related bloodstream infections that is performing very well with very high sensitivity and specificity. And similarly, this one is for fully automated surveillance of infections by Clostridioides difficile, for which the results, for example, show here with the black line that they are quite close to the results of the manual conventional surveillance, although they overestimate a bit the incidence. Meaning that the specificity is not always 100%. And this is often an issue with automated surveillance. And another example is the use of semi-automated surveillance for surgical site infections. Semi-automated is usually a bit more suitable for these kinds of infections where there is a need for clinical data. But these studies, and this particular one, which used criteria such as the taking cultures or antibiotics if the patient was readmitted or if they had surgery. And they showed that by applying these criteria, they could identify a subset of cases that had a high risk of surgical site infections, for which a manual review then identified with 100% specificity then whether there was a surgical site infection. So very, very useful, and also very important to keep in mind that there are currently, at least, the semi-automated may be better for some types of infection than fully automated. So keeping all these limitations for automated surveillance in mind, what could probably artificial intelligence add as value? We heard, as we said, for data extraction and case definition matching, main challenge is that a lot of data in the electronic health record are still unstructured, and mostly these are clinical data, like such as symptom signs or presence of invasive devices or radiology results. And often there is inconsistent terminology used or abbreviation. And this is an area where artificial intelligence can be of use, and that can be either natural language processing algorithms that can look into the clinical charts, or specifically even large language models such as, for example, the type of ChatGPT and others that are currently available. And in the last few years, there have been a number of studies looking at it. This one, for example, was using an NLP algorithm on top of a semi-automated algorithm, and applying to and comparing two different classification algorithms, a decision tree and random forest, to identify in the clinical notes text with some predefined keywords like abscess or antibiotic name, etc. This study didn't find a significant improvement with the use of the NLP algorithm, but compared to the semi-automated algorithm. But there is a lot. There is a very likely a lot of potential in this aspect. But why wouldn't we just use one of the large language models and feed it with the clinical notes and the definitions, and ask whether the patient, for example, has a healthcare-associated infections? And this is one approach for using large language models. And this has been, there are emerging new articles in the literature looking at this, like this one, where the authors extracted narrative clinical notes, anonymized them, and they prompted ChatGPT. And in two hospitals looking for surgical site infections after colon and colorectal surgery. And they found that the sensitivity was very high, but the specificity varied a lot depending on the hospital. And this is not strange, because of course we need to keep in mind that the clinical notes differ in different healthcare settings, and there may be lack of data, or there may be different habits of taking notes in its setting. And this is one of the challenges in this respect. We did the same in cases of what we use for training for persons who are performing the point prevalence survey. We have case vignettes to support the training and evaluation of these people. And so we have standardized cases, and what we did was feed some of these cases to a large language model. This was the prompt we use, and this is one of the cases, which is a case of catheter-related infection. And what we found, for example, in this case was that the model could very easily identify that there was a healthcare-associated infection, that it was catheter-related, but it didn't succeed in finding exactly the type of a catheter-related infection. But this is not totally strange, because for this particular case, for example, even the human raters only in a bit less than 50% identified the correct type, and 25% provided the same answer as the large language model. So a lot of potential here, but a bit tricky probably to still to have on clinical cases, although I mean in real clinical practice, although there have been efforts in this respect too. What are the significant challenges in this respect? First of all, there may be the model we use may be inadequately familiar with the clinical data, but there are ways to improve that. Data protection is a big issue, but then there could be use of a local model or a model compliant with data protection legislation. Data completeness is always an issue, which means that there is probably a need to have as much as possible better access to data and better and also make sure that we have improved improved clinical notes, or at least assess the availability of the clinical data. Of course, it's very easy to apply in one case, but I mean, consider if we need to apply that on all the patients in a hospital on a daily basis, then you can imagine the need for computational power, although this is improving considerably. And finally, one might say that, as we saw, that specificity might not always be perfect. So there are questions about comparability, and there standardization efforts are very important. So I think take-home messages are that for sustainable surveillance, we need, first of all, to make a conscious decision about what are our targets. They need to be relevant, measurable, and most importantly, actionable. We are seeing technological advances that make automation possible, leading to faster results and improved standardization. And there is both automated and semi-automated surveillance. They're becoming more feasible. There are algorithms that are validated and tested, and they will certainly make life easier for people doing surveillance. And this also is becoming more and more feasible with better implementation and more widespread implementation of electronic health records. Machine learning models to extract information from unstructured clinical notes has great potential, but there are still challenges. And with this, I would like to thank you and also thank my colleagues, both the chairs, Tommy and Angelo, for all their work in this area. Thank you.
Thank you, Diamantis, for the clear presentation. I would like to note that what we didn't mention in the beginning, that if the participants have any questions, you can use the questions and answers pane in Zoom to type in the questions. But as we don't see any questions so far, so maybe I'll use the little time before we have to ask at least about because we discuss also the feasibility of the surveillance and the different surveillance targets. So what Diamantis presented, what you presented is that commonly there are catheter-related PSIs and surgical site infections and Clostridioides difficile infections. But when choosing the targets, you mentioned also the actionability. So how much evidence we have of different IPC metrics that link to the prevention of these particular infections? So can you clarify a little bit, like how to use the IPC metrics and how then to link it to the action to prevent the infections?
Yes, thank you so much, Tommy. I think there are certain healthcare-associated infections for which we have very good evidence about how to prevent them, like the catheter-related infections or surgical site infections. There is also even for C. diff. So, and these are often targets for surveillance already in many places. So I think, but this is the holy grail, I think, of surveillance, right? How do we choose something that is preventable? And this is, I think, this should be number one in our list of reflections when we decide about surveillance targets. And there has been a lot of work recently in the recent years on preventability. And because very often we're talking about the burden of healthcare infections, but it's very important to see what part of that burden is actually can be prevented. Because obviously there are some infections that affect patients in hospitals that may not always be preventable. They're not always due to infections transmitted or bacteria and viruses transmitted from other patients. But there are also other reasons. For example, pneumonia is also very often an infection that can be prevented, but it may be difficult to define sometimes. And although there are case definitions for pneumonia, they very often depend on clinical features or radiological features that can be subject to various interpretations. So I think these also are factors that need to be taken into account.
Yeah, thank you, Diamantis. That clarifies a lot, like on the background of what is the important for the selection of the targets. Also, then looking into the future, if automating systems further. There's a question from Konstantinos that I'm trying to see. Just a second. Since several, like, this is a question on maybe if you have an opinion or a view on this, Diamantis, from a high level, like European agency organization, because since several hospitals have not yet implemented automation in surveillance, despite they have manual systems in place, how could the IPC professionals make the case to hospital administrators to get the support that is needed for implementing automation in surveillance? So do you have any view on what the IPC professionals could in practice do to convince the administration to give the resources for improved and automated surveillance?
Yes, thank you, Tommy. I think, of course, to make the case for surveillance, and I think it's a two-way process. Of course, bottom up is always something that needs to be in place, and of course, showing and highlighting the added value of automation in terms of limiting, making resources available for action. Because if you have resources will always be limited, right? We don't have endless resources in any setting. So making the case that resources that are now used to do the manual review of cases will be used for implementing interventions is, I think, a very important argument, but also that in the end, the use of automated surveillance is, streamlining, providing more standardized data are also factors that are important arguments. On the other hand, it helps a lot to if we also have a top-down process where we are in contact with networks. I mean, currently there is a lot of work at the European level for further developing automated surveillance. There are networks, there are people who are working on this at many levels. There are groups there are study groups in ESCMID, for example. So networking is very important in this case because there is a critical mass of people who are promoting automated surveillance, and this will trickle down to the local level. So I think this is also very important, and that's why the work of such groups and networking at this level is also critical to advance automated surveillance.
Thank you, Diamantis. Meanwhile, there was one question in the chat about the ECDC definitions for automated PSI surveillance, where I actually entered the answer already in the text format. And then there's one more question from one participant, that against the background of the EHDS and the focus on the exchange of data on antibiotic prescriptions and dispense, I am wondering why AMC surveillance has not occurred in your list of prospective use cases for automated surveillance. So antimicrobial consumption surveillance.
Yeah, I mean, yes. EHDS, of course, is a development at the European level. I mean, EHDS is a European health data space where data from electronic health records are envisaged to be used for providing care to citizens of the European Union wherever they are in the European Union. And there are also secondary uses of this data, such as one of these uses is potentially the use for public health purposes. And ECDC is working on looking into how this can be done in the best possible way, so that the data in electronic health records that will be shared through EHDS can be used to provide the data that are needed for surveillance. Automation of surveillance for antimicrobial consumption and use is also a very valid target. Actually, we didn't mention it because we're talking mostly about surveillance of healthcare infections. But we are looking, of course, and there are efforts for automation of this. Some countries even have it. It is definitely feasible, and it is definitely possible. Because there is no need for clinical data. There are some concerns about confidentiality, but in general, it's something that is a very valid action.
Thank you, Diamantis. That's a very clear answer. I think for the interest of time, it's time to move towards the second presentation. So I'll give the floor now to my colleague, Angelo D'Ambrosio.
Thank you, Tommy. And if the audience has other questions for Diamantis, please put them in the question and answer, and Diamantis will reply directly there. Okay, next speaker is Dr. Erika Shenoy. Sorry if the pronunciation is not correct. And she's the Chief of Infection Control at Mass General Brigham and the infectious disease doctor at the Massachusetts General Hospital in Boston, and also associate professor at the medicine of the Harvard Medical School. She will cover she will focus now on the AI part of HIA surveillance, and she will cover how these new technologies can help in surveillance, IPC activities, and also what are the opportunities and the limits of these new approaches. So, Erika, the floor is yours.
Great, thank you. Can I get a thumbs up that you can hear me and see the screen okay?
We can hear you. We can see the screen.
Excellent, great. Well, thank you so much for inviting me to give this talk. And as I was listening to Diamantis, I was thinking, we talked beforehand, but we didn't plan on, I don't think we realized how well our talks would kind of complement each other. And as I was listening to him, I was thinking what comes up a lot is human resources that are dedicated to surveillance. Of course, IPC is much more than surveillance. It's about acting on data and other aspects related to the environment of care. But to the extent that any of these technologies really support our human resources, make them more effective, take away work that then allows them to expand surveillance or expand their other activities, it could be really amazing for our field. So I'll start with one disclosure here is that I am not a computer scientist. I'm an infectious disease doctor who spends all my time pretty much nowadays doing infection control in a large healthcare system. So I'm really focused on the practical applications of technology, having done research in this area and continuing to collaborate with people. That's kind of the part of the world, but really what I'm focused on is what does it mean for the practical everyday work that IPC teams do. I have a couple other disclosures that are here. So I'll start with just a little bit of the what and the why, some definitions. I'll go through 5 use cases. A couple of these relate to surveillance, but some of these other ones are related to other activities that are really bread and butter infection prevention and control. And then just a couple comments of this phrase actually came up with Diamantis too, like, are we there yet? Where is this going? So what do we mean when we talk about some of these technologies? So AI is used like broadly. I don't think you can turn on the news or read a paper or whatever today without someone talking about AI applied to something. And I think generally the way to think about this is that it's a technology, usually computers, that are designed to perform tasks that are generally thought to be what humans do with our intelligence. So learning, problem solving. There's a subset called generative AI that many people are thinking about a lot today, is Gen AI or GAI. These are technologies that are actually going to create original content, so texts or images, memes that people may be using AI for. And it's based on patterns found in all the data that's out there existing. And in the healthcare world, it's being used for clinical note documentation, summarizing charts, patient messaging. So in the clinical world, that's how some of this technology is being used. Now, machine learning was mentioned by Diamantis. These are generally the tools and methods to look for patterns in data. And then the computers actually improve through experience, through training on data and then application and retraining. What can these do? Thinking specifically about infection prevention and control, they can increase our understanding of the current world. So identify the risk factors for infection. Again, the point of that would be to then figure out how to prevent those infections from ever happening. They could make predictions about the future, so tell us who will become infected, who will develop severe disease, again, in order to try to prevent it. And there are several types of machine learning. You'll hear about supervised, unsupervised, or reinforcement learning. And then deep learning is a subset of machine learning that is using more complex and numbers of neural networks. So I asked ChatGPT to create an image for me so I could use it for this talk. And after a few minutes of me prompting it, a little bit of frustration directed at ChatGPT, it came up with this diagram and came up with a couple examples for IPC for each of these. So automated surveillance, we already heard Diamantis talk about that, decision support dashboards, outbreak prediction, antimicrobial resistance. That question came up from the chat, and also antimicrobial consumption. And then for generative AI examples, synthetic outbreak scenarios, drafting IPC policy or training, and then these large language models, chatbots for IPC guidance. I'll give an example of that that's recently been published, and summarizing IPC research. So if you just want to look up a topic, you could use some of these models to help you do that. Another way of looking at this, and I like this because I think conceptually it helps us, those of us who kind of grew up in the pre-machine learning world, which was not that long ago, we did a lot of modeling based on thinking about a model, designing a model, fitting data to that model, doing the computation, getting results. But machine learning is very different from a conceptual approach because you put data into a computer that then generates the model that you then apply. And that's really made possible by the massive amounts of data that we now have available in healthcare and computing advances. And one way to think about this is we have so much data in the electronic health record. What I'm showing here on the top are trends in the United States of hospital and physician EHR adoption. This was driven a lot through legislation in the United States many years ago. So basically 100% of hospitals are using electronic health records. I found this report from the EU looking at various countries in the EU and their e-health indicator scores. And there's a lot of progress overall in Europe related to electronic health records. So there's just an explosion of the amount of data that is available to us. Now, whether that's structured, unstructured, how we can use that data is a totally different story. Computing storage and speed has increased dramatically. So on the top panel here, we're looking at this IBM computer that only had 5 to 10 megabytes, was incredibly expensive and very big. If you fast forward to one of the iPhones, it's got 512 gigabytes, is $900. So like just in orders of magnitude of advancement there. In the bottom panel, we're looking at instructions executed in millions per second, and that has just grown dramatically. And then lastly, the models are not just out there in some white tower academic sort of setting or in industry. These are actually coming directly to the end users. I asked ChatGPT again for this talk, create a table for me using my nice format of different use cases in healthcare and show me some example tools that are out there. I knew about like a couple of these, but I didn't know about all of these. So there is a lot out there that's bringing it directly to the end user, which I think is really transformative. So I just, disclosure, ChatGPT 5+ made this one. So let's go through some use cases specifically for IPC. So we talked a little bit about detection and surveillance of healthcare-associated infections. I'm going to take the example of CAUTI. And what Diamantis was really set me up nicely for this is that our current definitions, some of them are more, lend themselves more to automation or even semi-automation just by the fact of how they're defined by either the NHSN or I assume by the ECDC. You know, when they're very discrete about discrete elements, then full automation is actually quite possible, and you don't probably need anything too fancy to be able to apply that. But most of our surveillance definitions, while they have discrete elements, do require the chart review, that manual part, because we're looking for other elements that are either not discrete or require some clinical assessment. And the problem is really that this HAI surveillance is time consuming. It relies on humans to a greater or lesser extent. For the facilities that Diamantis described that are 100% manual, that is a lot of manual work. Many facilities, and I would think in the United States, just because of the commercial EHRs that are available, it's mostly semi-automated. And so there is assistance to the IPs when they're doing the surveillance. If we had a generative AI model to detect CAUTI, could we increase our efficiency and accuracy? And these are researchers who published this in January of 2024 in ICHI. They created some synthetic data sets to kind of mimic data that an infection preventionist would be looking at. They applied GPT-4. They asked it to analyze the data, identify CAUTI using the NHSN criteria and some other sort of tasks. And then they reported on the sensitivity, specificity, the NPV, and the positive predictive value, and they compared it to the gold standard. So in gold standard surveillance, there's patients, some have a catheter, some don't. Of those who have a urinary catheter, they found 5 using the gold standard surveillance that met CAUTI criteria and 24 that didn't. They put the same data set through GPT-4, and it did okay. It overcalled 1 CAUTI. So there was, it identified 6 CAUTIs, but actually 1 of them was not a CAUTI. Moving on from detection to prediction. So there's a group that I had collaborated with at Michigan, doing really amazing work in C. diff. And previously together, we had shown in 2 different institutions the development of a model, a machine learning model to predict which patients would develop C. diff in the hospital and predict it in advance of their actual diagnosis. Now, the team at Michigan took it many steps forward, and this is one publication recently where they looked at not only can we identify who is likely to develop C. diff, but who's going to have the highest risk of complications. The idea being that if we could identify these individuals, maybe we could target interventions to change the course of history and make it so they have a less complicated infection. They took this machine learning model, they applied it to historical labeled data of patients who had developed C. diff. They then trained it to predict the development of complications either on day 1 of diagnosis, 2, or 3. And then they evaluated it on a held out data set, very important in machine learning to make sure that you reserve part of your data set to evaluate your model. And then they compared it to a curated model. So this would be like a model that we're very familiar with. We have X number of variables or parameters that we think are important versus using all the data in the EHR, which again, with the advances in computing, we have access to. And what did they find? So the red line here, this is the EU-ROC. The red is the curated model, so using only those 23 variables. But the EHR model, which uses hundreds to thousands of variables, does perform better. Now, I mentioned that this group at Michigan really took it further. Well, this is just pretty hot off the press, published in JAMA Network Open this past June. They then wanted to say, well, we know who's at risk of C. diff. We even know who's at risk of severe complications. Could we use our tool to guide infection prevention efforts to target those patients and intervene upon them? And this is a real world application, which I think is very unusual in this field, to actually take it from the kind of conceptual, theoretical, validated model approach to trying to actually see if we can use it in real life. So what did they do? They took that previously validated model to predict who was at risk of C. diff infection, and they actually integrated it into the daily workflows in their facility. They generated a model score, and based on that model score, they then pushed interventions to the front line, to the clinical care team, on two buckets. One is reducing the risk of exposure. So they had a hand hygiene intervention. The second part is reducing the susceptibility of those patients to C. diff through antimicrobial stewardship. They implemented this for an entire year in 2023, and then they looked at what happened with C. diff incidence, antimicrobial use, and they did some qualitative assessments of bundle implementation. So just a couple screenshots. These are from the supplement if you're looking for them, if you decide to go read this paper. As I mentioned, the first intervention, and it's called a BPA. So I'm not sure the language in Europe on this, but this is a best practice advisory, and it's basically a push in the electronic record. And I'll show you a screen of this that the clinician will see, and you can target this towards different types of clinicians depending on how they've logged into the computer. And so they wanted to alert them, your patients at high risk. We want you to do enhanced hand hygiene. We want you to focus on reducing the susceptibility through potentially medication changes. And this is what they would see. So if you logged in and your patient was at high risk, you would get alerted that they're at high risk. The default is to order the enhanced hand washing sign. And so people are more likely to do what's easy, and they usually accept those types of BPAs. This one I think was really clever, because if this popped up on my screen and I was seeing a patient, I would look twice just because of the icon that they used. And you'll see that how effective this was. In this case, they alert them that they're at high risk. They default the order to the beta-lactam allergy evaluation service. And then you see what will happen in terms of outcomes. So what did they find? So no impact on C. diff. This is the pre-AI and post-AI samples, but big picture, no change of CDI. CDI incidence was already very low in this institution, but they did see a decrease in antimicrobial use. And if we zoom in here, you'll see that the amsulbactam and the piptazo and the clindamycin use decreased substantially. So to that question of antimicrobial consumption that was asked before, here is an actual intervention in real life that decreased consumption of antibiotics. And I think that's really phenomenal and exciting. So another use case is observation and assessment. One of the things that we do in infection prevention is really push hand hygiene. We know it's essential, but real world suboptimal performance. Direct observation is the gold standard, but it has its limitations. In this approach, they wanted to use computer vision, another area of technology, to observe hand hygiene use and determine if they could actually develop a model that would accurately identify individuals doing hand hygiene. And then they compared this to simultaneous human observation to figure out what the ground truth was. And what did this look like in real life? We're looking from the bottom up at a hand hygiene dispenser. Then there's this sensor that's applied above, and they did this in a single care unit in a hospital. This is a layout of this deep neural network that is using really fancy computer science that I don't understand. But really what they're trying to do is, can we, using this network, figure out accurately that someone is performing hand hygiene? So that's the prediction that this is making. And what did they find? Actually, the machine performed as well as the humans. You're seeing in the first line was the dispenser used or not used, and then the human versus the machine observers. Now, I would point out, even though this wasn't looking for compliance with hand hygiene, this was a proof of concept that could they or detect accurately use of hand hygiene. They noted more events of dispenser non-use rather than use. And I think that will ring true to all the IPC people out there that people don't use enough hand hygiene. But they still found that the accuracy of this compared to the humans was quite good. So lastly, I'll just talk about at the elbow IPC support. If there's something our IPs and our medical directors or healthcare epidemiologists are doing, it's dealing with questions that come to us all the time. We have a strained workforce, and the question here was whether or not large language models could support IPs or other frontline clinicians who may not have access to IPC resources or 24/7 access to IPC resources, because we know questions come all times of day. So they developed 31 sample questions in 3 domains: transmission-based precautions, communicable disease exposures, and environmental cleaning. They ran it through 4 commercially available LLMs, and then they rated them for accuracy and completeness. They compared it to their own facility guidelines. So they basically prime it with facility guidelines, put in the 31 questions and see how they do. They also did an approach where they looked at how did it compare if you just said use CDC guidelines. These questions, if you look at them, you've probably heard every single one of these. If you do IPC for a living, they're like everything that comes in on a daily basis about exposures and transmission and when can people be isolated. I was actually really interested when I saw this last one, which if you haven't gotten this question, I don't think you probably haven't been in IPC long enough, because I've certainly gotten this question. I saw a bat in a patient's room in the neonatal intensive care unit, and it's asking about prophylaxis. And I read this, and this paper was published in 2024 in preparation for this talk, and I thought, I've heard this very recently. And that's because a couple weeks ago in our neck of the woods here in New England, there was a report of a bat problem in a neonatal intensive care unit, and I started thinking, how did the research at Stanford's really predict that this was going to happen here in Maine a year after they'd published their paper? But in fact, there is literature out there, and that's what I expect the LLM was using in order to give guidance about rabies prophylaxis. Well, what did they find? GPT-4 did really, really well. Based on their measures of accuracy and completeness. There was a degradation when they used the CDC guidance, and I suspect that's because the CDC guidance is excellent, but it's often not specific enough for the question that you're getting, and facility policies tend to be much more concrete and directive. Here's a heat map showing the golder the better. And so you can see when you look across ChatGPT 4 that it did perform quite well, both on accuracy, a little bit less overall for all the models on completeness. So lastly, in the last minute or so, are we there yet? You know, in the US at least, really applying AI in healthcare is pretty elusive. This is a survey that basically showed that there's a lot of variability. And that full deployment is really low across the board. Really, the most place that it's been fully deployed is in clinical risk stratification, sepsis, admissions, and clinical deterioration, but other places, not so much. Major barriers include, I'll get to the barriers in a second, but the places where it's been used are in clinical documentation and risk stratification. You'll see IPC is not up here at all. And the major barrier is lack of tool maturity. And I think that's one of the big barriers in IPC as well. We haven't really determined real-time operational use or demonstrated. I think the team at Michigan, looking at their application in the real world for C. diff prevention is really interesting, but it's an unusual and rare occurrence that people actually get to the bedside with some of these tools. Training, validation, maintenance, and revalidation is very time-consuming and very resource-intensive. Now, to the extent that our HAI definitions become fully discrete, then that really does open up large potential for fully automated surveillance and risk prediction advances. I think you're going to need to see full integration into our commercial electronic records. Working outside of that is really hard for a number of reasons, but also it just doesn't work with our workflow. And then just to end up here, that I hope that this will actually augment our underforced resources instead of, I don't think displacement is really the word. I think that there's so much more we could do if we had more time and were able to deploy our resources in a more effective way. So the end story is, I think that it's decidedly uncertain what the impact of AI will be on IPC, but it's a really exciting time to be in this field. And I'll stop there.
Thank you very much, Erika. It was very illuminating, a lot of very nice literature suggestions. I will take some of them, know this. Currently, I see no questions in the question and answer chat box, but I can start the discussion. And Constantino, let me know if we go too much over time. So to implement this kind of technologies is complicated. It's something that, I mean, we as physicians and healthcare workers are not skilled to do. And so you need some specific expertise. In your experience, in your hospital and by collaborating with other groups and from the research, do you think it makes more sense to develop technical skills in-house in the hospital and healthcare system, or just to buy either consultancy or pre-made tools from external sources?
Well, I think it's going to totally depend on the size of your facility and how broadly applicable those resources are. I think it's going to be very difficult to make the case to bring those resources in just for example, your service line of IPC, but many healthcare systems are investing broadly in the technology. So there may be opportunities to leverage resources that are used in other departments or for other use cases towards your area. But I think practically, what is more likely to be more broadly used is if the major commercial electronic health record tools or other tools integrate this technology directly into it. And I think that is going to be able to support a small facility of 12 beds and support facilities of larger sizes. In the research world, it certainly would be exciting and to invest in the data scientists to collaborate with, and it's really exciting. And I think that's really phenomenal. But I think from a practical day-to-day sort of thing, that's going to be beyond the reach of most institutions.
Yeah, it makes sense, especially we need to divide small hospitals with very practical needs from big hospitals where they want to be more on the far edge of the research. And also, I mean, it's nice when we see these results to think that these are the worst results that we will get until now, because these models do increase such a rapid speed. You show GPT-4 results, but we already have GPT-5, we don't know. But this brings two more questions. And how to integrate this technology with the current IPC teams, so how to let them get confidence and use this technology. And it's not just in healthcare, but in all fields, people are starting to speak about the skilling issue brought up from these technologies.
Yeah, those are good questions. I don't have all the answers. A couple thoughts on them. I think IPC is so much more than surveillance. I know we focused a lot on surveillance here, but if I think of the daily work of IPC, environment of care assessment, infection control risk assessments for construction, renovation, water intrusion, all those sorts of things that IP knowledge brings to healthcare and reducing risk to our patients, I don't think displacement or that is in our future. What I do think it could help with is offloading some of the more rote tasks so that we can focus again. I'm kind of hearkening on what Diamantis said on the prevention part. Like, just identifying the infections is one thing, but then what do you do about it? How do you communicate that? How do you kind of change policies or practices? That is bread and butter IPC that I don't think will be replaced by these technologies, but could be augmented because we can use it smartly to assess the literature and pull things together. So I think it's all generally positive in our line of work because there is really so much more to do, and we're really, in some ways, very much burdened by the rote aspect of surveillance that it doesn't allow us to fully realize what we could do for our patients.
Thank you very much. And if there are questions from the audience, from the chairs, from the panel.
Yeah, I also wanted to comment, but Angelo beat me to it, about the risk of, making IPC professionals obsolete due to these technological advancements. But as you said, Erika, there are, I think, a big part of daily IPC work is based on behavioral aspects and communication issues. And it's going to be hard for this type of technology to beat the face-to-face, the human interaction. I mean, we have studies that have shown that these LLM tools can even show empathy while communicating, but I think there's still a long way to go to reach that point where an IPC professional will be beaten by a machine, by technology in that.
Yeah, I mean, I just want to end with one last thing. I know we're over time, is to be creative about how you might use these. I'll totally separate from what we talked about. I've been thinking about staffing models, resources that I might need for different sorts of settings in my system. And so I've been using GPT to create models for X number of procedures, square footage. Are they doing high-level disinfection or sterilization, and generating some ideas for me to think about resources. So that's a way that you could be using some of these technologies from an administrative point of view to support your IPC staff, to make some of those, what we were talking about, how do you make the argument for resources needed to do what you're going to do? You can plug in there estimates from the literature of HAI reduction, and you can actually generate some good tools for your own program to support why you need the resources to do what you're doing. So that kind of flips things around. It's not going to take away resources, but actually use it to analyze what resources you need. So that's another application.
There is a question from the audience, from Giulio. Why are IPC teams usually under-resourced?
Yeah, what's a great question. I think we're a core service. We are not a revenue generator. And I think on us, just to take full responsibility, if we're not advocating for how we reduce patient harm, patient risk, then we are not doing our job as well. But I think the other piece is it's a skill set. It's a niche skill set. Our IPs and the physicians who do this sort of work, it's like a super subspecialty. And I think that it's, bringing people into the field is challenging. I don't know how Diamantis feels about this, but I think there's two pieces of it there.
Yeah, so yes, thank you, Erika. No, I fully agree. I think the skills and in the field, there's an explosion, but on the other hand, there is really a huge challenge with finding the people who will do that, and there's a lot of competition. I mean, in general, healthcare workforce is not right now, anywhere on the increase, really, and it's a huge challenge for healthcare facilities to find the right people for the right job. So I think definitely then smart use of new technologies is something that could be really critical in this respect.
Especially, in this field where you are understaffed, having this kind of technology is very helpful. The problem is more when you are overstaffed, that since more senior people gets more powerful, let's say, more multitasking with this new technology, you stop to have needs for example, interns and new people or younger colleagues, and that could be a problem. But I think that for IPC, in which we are usually understaffed, we are for now safe from this issue. But in other fields, it's start to happen. So the developers are not, so big coding company are not hiring developers, young developers anymore, because a senior now can do the work of 10 people.
Mm-hmm.
Yeah, exactly. And the other good thing is even in areas where IPC is understaffed. I mean, for example, in our areas, our geographic areas here in South Europe, this happens a lot. But what we usually take advantage of is indeed the introduction of technology in other aspects in healthcare, and we kind of piggyback on that. For example, even introducing an EHR in a hospital, electronic health record, you can use that to enhance your surveillance that way. So yeah, you take advantage of technology and you compensate for the understaffing that, as you said, Angelo, I think it's always going to be a problem in our area.
Okay. I don't know if we have time or we are already 10 minutes after.
I think we're over.
But yeah, I think we're okay. Yeah, no more questions. I don't know if any one of you wants to add something before we close.
I just want to thanks Erika for the very nice presentation and Diamantis.
Well, a huge thanks to our speakers, Erika and Diamantis. A huge thanks to our chairs, Tommy and Angelo. Thank you all and all our attendees for being here. A big thank you to EU-JAMRAI for the support, and a very big thank you, very huge, if I can say, thank you to ESCMID for all the support and for the technological support, and also to Fernanda for her organizational support throughout all these webinars. So thank you everyone very much, and at least from EUCIC part, we'll see you again in the beginning of December with our next webinar. Thanks a lot. Bye.
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 Bye-bye. Thank you.
Thank you.